Thank you. I'd like to begin with a story. We'll call this gentleman Mr. Smith. He wakes up one morning, and he's got a rash on his arm. Looks at it, where the heck did I get that? Kind of itches, burns, doesn't have a clue. And so he does what all of us do. He goes to Google. He's still not sure after looking at it. And so he then goes back to Google and says, I got to find a dermatologist because I got a rash. And he looks at reviews. He spends 3 hours, looking for 4 stars, and finally finds a dermatologist in his health plan. And so he makes the call, and they say, oh, no problem. We take your insurance. It's all good. Doctor can see you a week from Tuesday. I guess a week from Tuesday? It's not that bad. It's not going to kill me. I can manage till a week from Tuesday. And then just before he hangs up, the person on the other end of the phone says, and if it gets any worse, you go straight to the emergency room. So a few days pass, the arm is starting to hurt. I'm not going to give you an unpleasant description of his rash, but he doesn't like how it looks. And he says, oh, I guess I should go to the emergency room. And he goes to the emergency room. And if you have family or you have been to the emergency room, you know what that's like. You sign in, you wait. They call you up, you wait. The nurse comes in and says, what are you here for? He says, I've got this rash. He types it into the computer. Doctor will be in a moment. You wait some more, and the doctor finally comes in, logs into the computer, is making no eye contact whatsoever with him at all, right? So what are you here for? And he says, I've got this rash. Doctor has to look away from the computer now. He has to look at the patient. And says, oh, that's shingles. And he says, no problem, we can take care of that. Back to the computer and starts typing that in. And Mr. Smith says, well, what does that mean? He says, well, it's chicken pox that you had when you were a kid. It's reactivating. We'll give you some medication. It'll prevent complications of it. How long have you had the rash for? And Mr. Smith says, oh, about 5 days. And the doc turns back and says, oh, no, that's no good. We got to start these medicines within 2 days of onset, for them to work. If we're going to prevent complications, you shouldn't have waited so long. Well, we'll give you the prescription anyway. Can't hurt, might help. We have a fail. This is a complete healthcare fail. Mr. Smith didn't get the medication he needed when he didn't get seen when he needed it. He didn't get the medication he needed, and he's gotten something that probably isn't terribly effective, and he has at increased risk of a complication from a treatable illness. It's not a disaster. This is not a story that ends terribly badly for Mr. Smith, but it is an example of the problem of healthcare in America today. And so I'm going to do the thing that you're not supposed to do in a TED Talk, but we'll get it out of the way. The U.S. healthcare system is broken. Everybody in the room already knew that, but I got it out of the way. What is broken about it, just in case you haven't been paying attention and you or your family have not been patients in the U.S. healthcare system? Well, on top of really impersonal experiences like Mr. Smith just had, we have really lousy outcomes. And the Mr. Smith story is repeated hundreds of thousands of times over the course of a year. In a recent study, when they ranked the health outcomes of nations across the world, the U.S. came in 35th. We came in 35th. We were squeezed out in 34th place by Slovenia, and I kept meaning to look up where Slovenia was, but I didn't, so I can't tell you where it is. Someplace in Eastern Europe is my guess. But they have a better health outcomes in terms of life expectancy, in terms of newborn morbidity and mortality, in terms of overall quality of life than the United States. And on top of that, here in the United States, we have a choice between fair to poor outcomes if you're white and really bad outcomes if you're black. And not only that, the health disparities in the United States, the inequalities have widened over the last 20 years. They're getting worse, not better. And for all of that, we pay more than every other country on the planet. So we have a broken healthcare system. So I'm supposed to talk about the T in TED is technology, and so I should be talking about all the amazing technologies that are happening. Artificial intelligence, proteomics, the exploration of the human microbiome, the fact that you can spit in a tube and send it off to 23andMe and, get your DNA sequenced. $99.99. But I'm going to talk about a little bit more old school. I'm going to talk about primary health care, which has been around since your grandparents. Because primary health care is, in study after study, shown to address some of the problems we're talking about. If we look at healthcare outcomes, those nations that have better outcomes have a higher rate of primary care per patient. In the United States, study has shown that if you have a primary care physician and you see a primary care physician for your medical care, you're 19% less likely to experience a premature illness than someone whose care is exclusively delivered by healthcare specialists. And if everybody in the United States had a primary care physician, we would save $69 billion a year in healthcare costs just by getting people hooked up with a primary care clinician. So this matters. This matters to all of us. But we should stop and go, we can do better still. We can reimagine what primary care looks like. So I want to ask you to go on that journey with me. About 100 years ago, though, William Osler is the founder, the godfather of American healthcare in the 20th century. He was a professor at Hopkins. Had an adage. He said it was more important to know the person with the illness than to understand the illness that the person had. Had to know the person. So I want to talk about a person-centered healthcare system, a person-centered primary care. So some elements of that. Some will be old, some will be new. Population medicine, continuous care, access, prevention, spectrum of care, team-based care. And then we're going to talk a little bit about new technologies that can only add to this. So when I say population medicine, what do I mean? I mean that Mr. Smith and all of us have a medical home, someplace that knows us and that expects to take care of us. So that that medical home knows this is the panel, this is the population of people I take care of. It could be based on insurance, it could be based on geography, it could be based on people choosing to get care there. But we have the responsibility for keeping that group of people healthy and helping them meet their health goals. And what that means is if a primary care clinician knows who they're responsible for, they can be proactive. They can go, you haven't had your flu shot yet. That mammogram, you're overdue. It's not entirely on you or Mr. Smith to get the care done. It's a partnership, and we can be proactive. So it's an emphasis on prevention. It's also a longitudinal relationship, though, which means knowing each of our patients, and Mr. Smith knowing his physician or nurse practitioner, knowing what to expect, knowing what they might be afraid of. So in the case of Mr. Smith, with that rash that turned out to be shingles, it's important to know not just this is the antiviral that he needs, but that he lives with a 4-month-old granddaughter who can't get a chickenpox shot yet because she's not a year of age. And so exposure to her grandpa may get her very sick. If I don't ask, who do you live with? How are we going to take care of that? If I'm not looking at the whole patient who's on an immunosuppressant, something that weakens his immune system because he has rheumatoid arthritis or he's currently getting cancer chemotherapy, I'm undertreating. So we have to know the person. We have to know the person beyond that too, because if I assume Mr. Smith can take a week off work while that heals up, I may not realize that he's a day laborer. Or if he doesn't show up at work, he's not going to get paid, and he's vulnerably housed. So I have to know more than just the disease. I have to know the person. Access. Remember, access was why he failed, right? We have to be better than the call up the doctor's office and wait on hold system we have today, right? So what can we do? We already have digital platforms. We already have the capacity to take a picture of the rash and send it, and someone in my office or I will see it and go, it looks like shingles. Let's get you some medication. He doesn't have to even get out of his pajamas. Or we can do video visits, which is something we're doing already today. So we can interact over the phone in real time, and he can ask questions and we can answer it. And again, we have to be able to do that across a spectrum so that it's maybe a simple rash, or I may be addressing his comorbid depression. We heard about traumatic stress. We recently finished a study. 30% of people over 65 that we were taking care of had experienced levels of PTSD, a rate higher than Gulf War veterans returning home, in just older adults with depression. We saw this PTSD. So we have to take care of the whole person, not just the rash, not just the heart failure, but the whole person. But how are we going to do that? That's a lot to lay on one person. And you can't. So the new primary care, the Reimagine primary care, has to be about teams. In fact, the physician really should be the last point of contact. The front desk staff always knows the stories. You know, they're the ones who come back and they say, he's having a really bad time today. They're the ones who are the first person to greet. They're the ones who help people shape their problems for the clinician. And they're essential. If you don't think they're essential, one of my partners is a wonderful family physician who has become an expert in transgender care. And if our front desk staff misgenders that person coming in, they're turned around and they're going out the door and they're not getting care. So that front desk is important and part of our team. The medical assistant who greets and finds out what's going on, our nurse practitioners who educate and screen and make sure people get their preventive care, the pharmacist who consults when I've got to juggle 8 different medicines and I know something may interact, our social worker who addresses my patient who's about to lose their home or about to have their electricity turned off. It's a team effort. And it's a team effort increasingly because we're learning more and more about each other every day. It used to be that what I knew about a patient was what they told me in a history, what I found on physical exam, and the labs I ordered. But now we're getting glucose readings that they're checking at home and blood pressure that they're monitoring at home. I'm getting Fitbit data. Dr. Rothschild, I walked 10,000 steps today. We're starting to get more information about Dr. Rothschild. Mr. Smith hasn't filled his medication from the pharmacies. And increasingly, we're getting public health data. Here in Chicago, we are so fortunate. There's something called the Chicago Health Atlas. If you're not familiar with it, I encourage you to look it up. It's a free resource. And you can look at the neighborhood level about incidence of disease, but also how far it is to the nearest healthy grocery store where you can get fruits and vegetables, or how safe it is for people to walk around in that neighborhood. So that as a clinician, it's not just me saying, well, go exercise, go walk around the block, without knowing that it's not safe for them to do so, or they may fear it. So we have all this growing information, and eventually we will have the artificial intelligence and the predictive analytics to help us integrate all of that into a care plan for our patients that we form together. Because we're going to go back to Osler. It is important to know about the disease that our patient has, but it's more important to know about who that person is, to know their story, to know their experience, to know what's important to them and what's not important, and to deliver holistic care that takes all of that information and wraps it around the patient in a way that allows them to be healthy. Thank you very much. Okay.